All right, let's jump right into this high-yield explainer. We're covering the absolute must-know mechanisms of transplant pharmacology and rejection kinetics. And we are operating on a peer-to-peer level today. If you're looking to master an integrated mixed block simulation, calibrated strictly for a perfect 270-plus score, you are in exactly the right place. We're going to deconstruct the precise mechanisms, the diagnostic traps, and the definitive management steps you absolutely must know. Let's get started.
Module 1, Calcineurin Inhibitor Toxicity Profiles. We're bypassing the pleasantries here and looking right at their aggressive side effect profiles.
So the crucial point right off the bat is understanding the shared destruction. Both cyclosporin and tacrolimus strictly inhibit calcineurin. This halts the dephosphorylation of NF-8T and completely prevents IL-2 transcription, which, as you know, effectively cripples T-cell activation. But here is the cost. Both of these agents aggressively drive dose-dependent afferent arteriolar vasoconstriction. This leads directly to severe renal damage, hyperkalemia, and systemic hypertension. You are essentially choking off the kidney to save the graft.
Now let's look at the divergent toxicity profile, because the shared renal and vascular damage is a given, but the unique side effect matrices are how you actually distinguish these agents clinically. Cyclosporin exclusively drives that classic gingival hyperplasia, the swollen gums, and excess hair growth or hirsutism. Tacrolimus completely lacks these cosmetic effects, but it comes with its own aggressive profile. It is highly neurotoxic, causing resting tremors, and heavily diabetogenic, leading to impaired insulin secretion and new-onset fasting hyperglycemia.
Let's lock this in with a clinical variance box. If you are presented with a post-transplant patient who has new-onset hypertension and swelling gums, that strictly implicates cyclosporin. Conversely, if that exact same patient is developing new-onset fasting hyperglycemia and resting tremors, completely without those cosmetic changes, it points directly to tacrolimus. You absolutely must be able to isolate these immediately.
Module 2, Transplant Rejection Kinetics. We're moving along a timeline here, from minutes to years.
This timeline is brilliant. It perfectly illustrates the chronological progression of solid organ rejection, anchoring you to exactly when these immunological attacks occur post-op. Recognizing the time frame is your first and, frankly, often most critical diagnostic step.
Let's detail the exact mechanisms at play. Notice how hyperacute rejection hits in minutes to hours. It's driven entirely by preformed recipient antibodies against donor HLA or ABO antigens. That's a type 2 hypersensitivity reaction. The graft immediately models and becomes cyanotic due to widespread microvascular thrombosis. Next, we have acute rejection, typically weeks to months out. This is primarily a CD8-positive T-cell-mediated attack against donor MHCs, a type 4 hypersensitivity. The definitive biopsy signature you're looking for is a dense mononuclear lymphocytic infiltrate. Finally, chronic rejection occurs over months to years. Here, CD4-positive T-cells respond to recipient APCs presenting donor peptides, which drives irreversible smooth muscle proliferation and obliterative fibrosis.
And this right here illustrates exactly why recognizing acute rejection is so critical. Unlike the chronic phase, which is an irreversible obliterative vasculopathy, the acute cellular infiltration is entirely salvageable. But, and this is a big but, you must confirm it with a biopsy of the transplanted tissue. Once confirmed, it's readily reversible with targeted immunosuppression, primarily high-dose IV corticosteroids. If it's refractory, then you look to alternatives like anti-lymphocyte antibodies such as OKT3.
Here is your second clinical variance box. This helps you immediately isolate these presentations based solely on their underlying pathological kinetics and salvageability. Hyperacute mandates emergent graft removal. Acute features lymphocytic infiltration and is medically salvageable. Chronic features obliterative fibrosis and ultimately mandates retransplantation.
Module 3, Opportunistic Prophylaxis Mandates. Let's look at how we guard the gates of a completely suppressed immune system.
So the key takeaway here is your absolute mandate for a fungal and protozoal shield. Universal prophylaxis explicitly demands trimethoprim sulfamethoxel, or TMP-SMX, for the first 6 to 12 months post-transplant to cover pneumocystis jirovecii and Toxoplasma gondii. This is so critical that even if a patient has an allergy, you will run a sulfonamide desensitization protocol prior to transplant just to ensure they can tolerate it. Additionally, if you're moving into anti-TNF-alpha territory, screening for latent Mycobacterium tuberculosis is heavily mandated because you're risking the breakdown of protective granulomas. You also have to map cytomegalovirus risk. If the donor is CMV positive and the recipient is negative, prolonged valganciclovir is strictly essential.
Module 4, the Master Case Blueprint. Now, we are going to simulate a scenario that demands flawless execution.
All right, let's look at the ultimate diagnostic trap. It forces the differentiation between early acute cellular rejection and calcineurin inhibitor nephrotoxicity. Both of these present with worsening renal function. So how do you definitively distinguish them?
Let's construct the blueprint. Imagine you have a renal transplant recipient, let's say 4 months post-op. They present with a steadily rising creatinine, newly elevated blood pressure, and oliguria. Notably, they completely lack a fever or any graft tenderness. They are maintained on tacrolimus, and we're going to embed a trough level that sits right at the high normal or slightly supratherapeutic range. This blueprint isolates a patient with declining renal hemodynamics, where both the life-saving drug and the host immune system are the primary suspects.
And this matrix perfectly breaks down the exact pharmacological adjustments demanded by actual exam conditions. The prompt strictly demands the interpretation of a renal biopsy. If the biopsy shows endotheliitis and dense mononuclear infiltration, well, you have acute rejection. In option A, IV steroids is your immediate mandated step. However, if the biopsy shows isometric tubular vacuolization and no significant infiltrate, you're looking at CNI toxicity driving afferent vasoconstriction. In that exact scenario, option B, decreasing the calcineurin inhibitor dose, is the only correct maneuver. Option C is just a distractor. TMP-SMX is prophylactic. It doesn't treat AKI. Option D is held in reserve as an alternative for refractory cases, and option E is completely wrong here, since emergent removal is solely reserved for immediate hyperacute reactions.
I'll leave you with this provocative thought. When the margins are this incredibly thin and a patient's creatinine is climbing daily, which mechanism will you bet the patient's graft on? Are you going to assume rejection and hammer them with steroids, risking further opportunistic infections, or assume CNI toxicity and lower the dose, risking an unchecked CD8 T-cell attack? The biopsy is your only definitive shield against a catastrophic error. Master these parameters and you master the ward. Keep reviewing, keep integrating, and I'll see you in the next explainer.